thank you, Dr. Rajiv Raman. Thank you, Indian Orthopaedic Association and Maharashtra Orthopaedic Association for this invitation. Taking the wonderful presentations by Swarninduda and Bhupesh ahead, one important topic of meniscus repair, which I think especially for the youngsters is very important because there is a lot of anxiety with regards cost and with regards the technical details. That's my profile as a dedicated arthroscopy surgeon. I practice in these hospitals in Mumbai. Just two or three important anatomical points. As far as the meniscus is concerned, we know there is a medial and a lateral. It's a fibrocartilaginous structure. The medial is larger as compared to the lateral meniscus. The intermeniscal ligament connects them in the front. The root of the menisci on the medial side, through the shiny white fibers, gets attached to the posteromedial tibia. And that's an important landmark in terms of not causing any iatrogenic injury in this area. The lateral meniscus root through the meniscofemoral ligaments, which is attached in front of the PCL and in the back of the PCL, like ligament of Humphrey and Risberg, make the lateral meniscus more mobile as compared to the medial meniscus, which is likely to get injured because of less mobility. As far as the vascularity is concerned, we know that the meniscus gets its vascularity from the geniculate plexus. Steve Arnoxy has talked about the perimeniscal capillary plexus. The importance is that from this capillary plexus, the vessels penetrate inside the meniscus up to its middle third only, making the inner third avascular. So the repair techniques are primarily reserved for the outer two-thirds of the meniscus. And therefore, the zones have been described as red zone, red-white zone, and white zone. So effectively, the vascularity comes only up to the red-white zone, and that is the take-home message based on which the zones have been described. With this understanding, quickly going through the tear patterns, when the tear occurs along the axis of the collagen fibers, as in number one that has been pointed out, it's called a longitudinal tear. When the tear happens through and through the meniscus, it's called as a horizontal cleavage tear, as in number 2. When there is a flap tear, as in number 3, or also called as a parrot beak tear. When one of the portion of the meniscus buckets inside the knee, it's called as a bucket handle tear, as in number 4. And when the tear happens perpendicular to the collagen fibers, it's called as a radial tear, which is one of the most biomechanically devastating injuries to the knee. Quickly, a case scenario: a young male who's had an ACL injury and a locked knee because of a bucket handle meniscus tear. These are the classic MRI findings, the double PCL sign and the meniscus lodged in the notch. The axial image tells me that this is a reparable tear because the tear is coming from the outer healing vascular zone of the meniscus. And this is the classic tear pattern that we see. So the first thing is to assess the tear pattern. This is the bucket handle meniscus tear. I have selected this tear because this tear involves all the three repair techniques. That is the outside in, the inside out, and the all inside. Before your meniscus repair is starting, start with the pie crusting. I feel for the joint line. I take an 18 gauge needle and I start making multiple fenestrations just distal to the joint line. So not at the level of the joint line, just distal to the joint line, gentle valgus, multiple pie crusting fenestrations in the superficial MCL posterior portion, and that opens up the joint well. With this opening up, the meniscus, which is bucketed, can be reduced. And not only that, you can find out the exact zone of the meniscus. Like here, you can see that it's a zone 2, almost the red or almost like the red-white zone, which is amenable to repair. So that's the advantage of the pie crusting. Also, there is limited cartilage scuffing because there is adequate space and your sharp instruments will not damage the cartilage. Another important tip to remember is that all your devices should be placed perpendicular to the collagen fibers. Imagine that the collagen fibers are like noodles. The chopsticks are like the meniscus repair devices. If you go parallel to the noodles, you can never hold them firmly. And the same principle is applicable. If you go perpendicular to the noodles or the collagen fibers, you can hold them firmly. And that is the idea of always trying to take vertical mattress stitches. And that's the take-home message. Wherever possible, take vertical mattress stitches. And that is going to be the most biomechanically strong construct. Before you start the meniscus repair, do the biological preparation with the diamond rasp. Initially do it on the capsular side like how you saw. Then do it on the meniscal side. On the meniscal side, you do it both above and below the meniscus. You then take a small awl or a needle and make multiple vents inside the meniscus to stimulate that perimeniscal capillary plexus, which we saw, so that vasculature comes from the perimeniscal capillary plexus into your repair. With this biological preparation, with adequate amount of space being opened, we'll discuss the first technique, that's the outside in technique, which is suitable for tears all the way from the anterior horn up to the mid body. And it's a cost-effective technique, so everybody should be aware of this. There are special mender systems available, but you don't need them if there is a cost constraint. Basically, you need a loop either of a simple ethylon or of the stainless steel. The loop of ethylon is cost effective. So you just take a number 1 ethylon, pass it through an 18 gauge spinal needle and prepare a simple loop. And this is the technique. So this is the anterior portion of the medial meniscus. This is the right knee. The visualization is from the anterolateral portal. You come with your simple spinal needle, which doesn't have the loop above the meniscus. Give a counterforce with a hook probe. Come with the spinal needle with the 18 gauge loop through the meniscus. Pass the above needle inside this loop. Load the above needle with a number 0 fiber wire. Hold that fiber wire with a hemostat and retrieve it through the medial portal. So you have created the loop now. Withdraw both the needles and you will pass a vertical mattress stitch. So that's simply how you can take a stitch above. You can see there are 2 stitches which are passed. You can pass one more underneath. So you go alternating stitches above and below, and that's the outside in technique. Coming to the inside out technique, which has become my workhorse since almost more than a year now. And you can do the inside out repair all the way from the mid body, all the way up to the posterior horn and the root. And that's the area which is amenable to inside out repair. What we follow in this is that we take a safety incision, and I'll share my tips and tricks as to how you can take the safety incision. So this is again the right knee. The scope is in now the medial portal. The scope is in the anterolateral portal. Pike crusting is being done. After that, you shift the scope to the anteromedial portal, and the hook probe comes from the lateral portal. We are still visualizing the tear. So the hook probe is coming from the anterolateral portal. Push it into the posteromedial recess and drop the knee into 90-degree flexion. So this hook probe can be palpated when you are creating your posteromedial incision. Like in this case, it's the left knee. The hook probe is coming from the anterolateral portal. You can palpate it in the posteromedial corner and take a vertical incision. The landmarks for that are that skin, subcutaneous tissue. Once dissected, you'll see the fascia, and then you incise the sartorius fascia. You go in the interval between the posteromedial capsule at the back, the superficial MCL in front. The posteromedial capsule is visible. The medial of the gastroc is at the back, and the hamstring tendons are inferiorly. So incise the sartorius fascia, do the blunt dissection, and identify this interval between the medial head of gastroc in the back, posteromedial capsule in front of you, and the hamstring tendons inferiorly. And place a protective spoon in that area, which will protect the neurovascular structures. So that's how you can start passing multiple stitches now. Hook probe is guiding you, and that is exactly where the direction and the needles will be coming through. You can create the same incision on the lateral side and dissect in front of the lateral head of the gastroc. You need not have this full set with you in multiple directions. You can just keep a single lumen cannula, which can rotate in 360-degree direction, so that you can manage above and below the meniscus, as you will see in the video. So that's the hook probe coming in. So you're visualizing from the anteromedial portal. The needle cannula is coming from the anterolateral portal. This is the undersurface stitch. We just pass through the meniscus, drop the knee to 70-degree, and your assistant will hold that needle from the posteromedial portal. The same single lumen cannula will take the other end of the needle, which is preloaded with a fiber wire, and you pass the needle, second needle again, which is retrieved at the back, creating a vertical mattress stitch. And when you pull on it, when the undersurface stitch is pulled, you'll see that the meniscal flaunce is restored. So multiple such stitches I used to pass in the back and used to cause a lot of confusion. Now, what we now follow is that as you pass the stitches, once it is passed through the meniscus, in this case, I've taken a horizontal or oblique vertical mattress stitch, immediately tie off the stitches with multiple half hitches using a knot pusher. So there is no confusion, and you keep on passing stitch in alternating fashion, one above the meniscus, one below the meniscus, about 4 to 5 millimeters apart, and make multiple such stitches, which will be extremely biomechanically strong. You can see the knee has been brought into near extension to restore the hoop stresses. So these are the tips and tricks. Hook probe technique, creation of a safety incision at the back, protective spoon, and pass your stitches in vertical mattress fashion and tie them immediately. So that covers my inside out technique. All inside technique is obviously the fastest of all, easiest of all. However, it is not cost effective. It is good for the posterior horn and the area near the root. You have got multiple devices which all have got the measurement gauge, which you can set to usually around 14 millimeters. Always remember, especially on the lateral meniscus side, that the neurovascular structures are very close to the lateral meniscus root, and therefore do not come from the ipsilateral portal. So this is the left knee don't come from the anterolateral portal, come from the diagonally opposite portal. Do not direct the needle towards the midline. Like you see here, it should be directed away from the midline. And that is the picture which tells you that it comes from the diagonally opposite portal so that the vessels are safe. Always use a slotted cannula so you don't scuff the cartilage. That's a quick video of how we use these devices. So once you pass through the meniscus, there is a snapping mechanism. You can either use your thumb and index finger, or you can use a snap mechanism like this. Withdraw it back, pass it again, and then snap it back again. So that's a quick video. I reserve the all inside technique for stitches near the root only nowadays. Even this area is accessible to all inside out technique, but technically a bit demanding. And as you tighten it, the suture is shifted towards the second anchor, and you've completed a nice bucket handle meniscus repair with outside in front, inside out in the middle, and all inside at the back. This is the final appearance of another case of a left knee bucket handle meniscus tear. And quickly, I'll go through just in a minute, in 2 minutes, of a radial tear of the lateral meniscus. This is a very common association with ACL. We are preparing it with the rasp. The principle that I just told come from the diagonally opposite portal. In this case, I'm coming through the trans patellar tendon portal, directed away from the midline. Use the hook probe like a counter force gently, and you can do a quick radial root repair. Sometimes it is not possible, and this device makes your life very easy. The antegrade device, one of them is the knee scorpion. And last two videos, if you have a radial tear like this where the meniscal quality is very poor, your fast fix device will just cut through these poor quality tissue. So you come with your 0 number fiber wire loaded on the knee scorpion, pass it through the flap on the root side. Now the lower part of the fiber wire, the lower stitch is retrieved and loaded onto the knee scorpion, and the upper stitch is retrieved into the trans patellar tendon portal. You pass the second stitch now through the lateral part of the flap. You then place a cannula in the anterolateral portal, retrieve both the sutures which are stationed in the trans patellar tendon portal into this cannula, and then you can tie a sliding knot, multiple half hitches. So poor quality tissue, flap, radial kind of tears, this is a boon for such tears, and that probably completes almost all the armamentarium you need to manage various type of meniscus tears. If there is no ACL reconstruction, you need to do extra biological preparation in the form of a notchplasty like I've done here in front of the intact ACL, and then multiple microfracture vents are created in the notch, and that's the completed repair of one of the cases. So these are the various factors and tips and tricks that I wanted to share. My take-home message is all three meniscus repair techniques, you need to be mastering it along with the knee scorpion technique. Outside in and inside out repair, when they are used, are cost effective. They cover the meniscus all the way from the front to the posterior horn. And whenever possible, when you use vertical mattress configuration, it is possible for you to provide the best biomechanically stable repair configuration. Thank you.